welcome to our Zoom tonight, and Dr. Georgiou welcomes you. He will say a word in a minute when he will take the floor. Ladies, gentlemen, good evening. On behalf of the Global Lipoedema Awareness Group and Dr. Iakovos Georgiou Lipoedema Patients Group, again in Facebook, we welcome you to tonight's event, which is part of our Global Lipoedema Awareness Month and Global Awareness Group's educational sessions with surgeons from various capacities. The global group was created in 2016 with the sole objective of educating patients about lipoedema who opt for the surgical ways. We are not into conservative treatments. Since then, we have helped thousands around the globe, and today the Global Lipoedema Awareness Group, with a capacity of 26,700 members, has an outreach to more than 100 countries, has a list of over 200 lipoedema surgeons globally, and all together now we are a huge family, the largest in the world, and the group is not alone, Marias. The group is big because of all of you. It's a global effort to have this magnitude, this group, which helps globally as well. We are not into specific countries, we are in global countries. Tonight, we have with us Dr. Iakovos Georgiou. He happens to be from my homeland, Cyprus. I have been living in London 33 years, and this is where I will stay for the rest of my life. But I am happy that tonight I have the opportunity to present a compatriot, a genuine, a great doctor, a human being, a gentle soul, and all the qualitative adjectives I can find in the word, they go to Iakovos. I call him with the first name because he's like a son to me. I'm old enough to be his mother. But tonight, the event belongs to Dr. Iakovos Georgiou Lipoedema Patients Group. We have with us Margaret Skinner and Michelle Craston. Christine Ellis, unfortunately, she feels unwell today. She will watch the video later. At this point, I would like also to thank Lipoelastic, who sponsors the event. The sponsor comes in discounts. Any discount that anyone gives us goes to the group. We don't benefit financially from any of our activities. We thank Lipoelastic. With the code LipoGarments, we get 15% all these years, while others, they get 10%. My thanks also go to the administrators of my group, Mia, Maureen, Juliana, Patricia, Teresa, Antonia, who helped me behind the scenes with this huge task in order to deliver and help our community. At this point, I would like to ask Michelle to do a short presentation of Dr. Georgiou. And also, I would like to welcome Dr. Manavella Chapero from Rosario, Argentina. He's a lipoedema surgeon as well. And in Argentina, I think he's the only one, maybe they have another one. And we would like to connect doctors globally. He's connected with Dr. Georgiou for some time now. And today, me and Dr. Georgiou have invited Dr. Manavella to participate to our presentation. Next week, we have Lipedema Argentina and the global group. We have Dr. Manavella for the South American patients. So, Michelle, the floor is yours.
Oh, lovely. Thanks, Maria. And hi, everyone. I'm so looking forward to this session tonight. But it is my absolute honor to be able to introduce Dr. Iakovos Georgiou to you all today. If you don't already know, Dr. Georgiou is a surgeon working currently as the head of plastic surgery at the German Medical Institute in Cyprus. In terms of his background, he completed his medical degree at the Charles University in Prague before moving to Germany to complete his surgical training and begin his practice specialising in plastic, reconstructive and aesthetic surgery under the supervision of Dr. Gods. And thankfully for all of us, it was during this time that Dr. Georgiou was able to specialise in the diagnosis and treatment of lipedema, a specialty that he continues to lead on to this very day. Aside from being a truly exceptional, talented and brilliant surgeon, as Maria has already said, he is also, without doubt, one of the kindest souls that you will ever meet. He is genuine, honest, and has a compassion and empathy for his patients in a way that I have never seen before. So when you're a surgeon like Dr. Georgiou, well, it's a complete understatement to say that the experience is life-changing. And today I hope you get a chance to see a bit of that for yourselves. So without further ado, I'll pass you over to Dr. Georgiou, who will introduce himself and take us through his approach to all things lipedema. Over to you, Dr. G.
Hi, Michelle. Hi, Maria. Hello, everyone.
Hello.
Thank you to both for really such a really beautiful words. I'm really humbled. It's very lovely to see many of my patients also part of the meeting. I tried to keep my presentation as short as possible so that we have enough time later on to answer any questions that I can. So, Maria and Michelle, if you agree, then I would start with the presentation.
Yes, yes.
All right. So I suppose
you can share the screen. You are a co-host in the group, so
okay.
you can act as if you are if you're hosting the yes.
All right. So let me just. Can you see my screen? Is that okay?
Yes, yes.
All right. Okay, so in regards to my biography, I don't think I need to say too much because of the wonderful introduction that Michelle already did for me. But I think it's only fair that I always mention Dr. Gotz by name. Without him, I wouldn't be where I am. And I learned a lot from him, not just in regards to lipedema, also how to head a department, how to all aspects in life. I've learned a lot from him, and I will always be very grateful to him. I moved back to Cyprus last year. Since then, I've been head of the department here at the German Medical Institute. It was previously known as German Oncology Center. Maybe you have seen more of that in my biography, but the rebranding stage has started. So that we are currently named German Medical Institute to show that we are not just involved with oncological patients. My primary focus, as Michelle has already said, is lipedema diagnosis and therapy, but also reconstructive breast surgery. I was trying to find some photos of us, Maria. This was the very first photo that we took together. It was, as you can imagine, right in the beginning of 2020, I think December. COVID. Yeah. And we needed to meet at the beach with the masks. I found that kind of funny. The one next to it was exactly 1 year after that. So we had already reached some level of normalcy again, and we're able to spend some time around Christmas together. So I don't really think I need to introduce Maria because everyone knows Maria. The only thing I can say, I don't think there's any single person that has done more for the international lipedema community than Maria. Without Maria, there wouldn't be an international lipedema community. Not just me, but all surgeons dealing with international patients. We owe a lot to Maria, and really the way that she raises awareness on lipedema is exceptional.
Thank you.
And the second person that I really would like to thank is Michelle. So as you can see from the photo, on the day I met Michelle, I was a bit tired. So the reason, one of the reasons why I'm so grateful for Michelle, she has made my life and my day-to-day much easier. She has helped me so much post-surgery. We met in Cyprus because she came over for surgery, but she helped me afterwards with such constructive, not criticism, but ideas on how to improve my practice here. She really brought many of my patients together, and really that has helped me quite a lot because patients helping each other, of course, and asking people that have gone through the process the questions really does make my life much easier. So Michelle, really thank you so much for everything that you have done as well. So I'm just going to give a short overview about lipedema reduction surgery or functional liposuction. I think lipedema reduction surgery currently is gaining much traction, this term, and I like it because many people still, when they listen or hear to the word liposuction, immediately they think of aesthetics. Of course, we know that lipedema is a disease. We know that it's a functional disorder, and functional liposuction has many differences to aesthetic liposuctions. But still, we need to be clear a bit on the nomenclature. So we have different kinds of liposuction. We have TAL, PAL, WAL, and ultrasound-assisted liposuction. Just a couple of words on each. So tumescent-assisted liposuction, initially, basically tumescent solution is what we infiltrate the tissue with before the start of the liposuction. There's many different constitutions. The most commonly used component of tumescence is adrenaline. By strict definition of TAL, we mean also that the solution contains some form of anesthetic, so that many colleagues, at least plastic surgeons, they use TAL as an awake procedure. That's not my case. I do all my cases in lipedema in general anesthesia. It's a hot topic at the moment. What is best? I don't think we really need to get into it, but I know colleagues that are very good and they do this procedure in not general anesthesia with very good results. I think whatever you do, you should be very familiar with and to know how to deal with that and do it in a safe way. So I think that's one option that should be discussed. Then we have PAL, which is power-assisted liposuction, basically meaning that the cannula, the part of the liposuction equipment that goes under the skin to actually remove the fat, it kind of vibrates. It's also known as vibration-assisted liposuction, which is more or less what I was doing almost exclusively in Germany. I was using micro-air back then. Brilliant technique, really good for especially large volume stage 3 liposuctions. And it's still, to this day, one of the techniques I use. We also have WAL, or water jet assisted liposuction, which means that the cannula is spraying water or solution during the liposuction so that it kind of helps detach the fat cells from the connective tissue and help us get the lipoaspirate out. Also a very good technique. Many colleagues have been using it for years or even decades. Probably because of my training, it's not my favorite technique, but definitely not something that I'm frowning upon. And we also have the ultrasound-assisted liposuction, most important example, which is Vaser. Vaser, we always say it kind of melts the fat. It doesn't really melt the fat, it emulsifies the fat, and it's not liposuction by itself. So basically, it emulsifies the fat and helps you perform some form of liposuction thereafter to actually remove the lipoaspirate. So that was one of the major differences from my time to Germany. I integrated Vaser into my technique with, at least from my perspective, many advantages. I also see some disadvantages, but still the advantages outweigh the disadvantages, and that's why I'm not really seeing a reason why I should stop using Vaser. The major advantage that I saw is that the lipoaspirate is much less bloody. So I have a much smaller drop of hemoglobin afterwards. I've never needed to transfuse a lipedema patient since I've been back here in Cyprus. Not that I needed to do it very often in Germany, but still, you do see the lipoaspirate quality. It's much more yellow. It's not as bloody as it was with just power-assisted liposuction. So that's definitely one of the advantages. The major disadvantage, though, of Vaser is the leaking. So I do leave the incisions open. In my case, I used to, as Dr. Goetz always was advocating for. I used to close all my incisions back in Germany. Right now, I'm leaving the incisions open with some drains being placed. Also, after discussion with Dr. Bruno, which I had the good luck of following his Zoom last year. So yeah, I think because of the extra leaking that you have in Vaser, you do need to leave the incision. Hopefully you do have more leaking, but that's why I leave my patients at least 3 days in the hospital. And this is the major stage of leaking, so that they don't really need to deal with that when they're back home, back at their hotel or Airbnb. So all these techniques that can be used for lipedema reduction surgery, many of them can be used, they can be combined. At the end of the day, though, we're performing a large volume. We need to remove a lot of lipedema fat to achieve a stable result. We're performing it in a multi-stage manner, meaning that especially in stage 2 and stage 3 patients, that we, in any case, we're not allowed to go over the 10% limit of the total body weight. It means that we cannot do everything in just one surgery. We need usually at least 2 to 3. Limb sparing technique, meaning that we are always going longitudinally along the axis of the leg to avoid or at least decrease the risk of injuring the lymphatics. We're doing it in a wet technique with the tumescent solution that I mentioned previously. And we're performing a functional liposuction, not an aesthetic liposuction, with many differences. We're not doing crisscross, for example, with functional liposuction. We're placing more incisions with a functional liposuction to avoid the necessity of going crisscross and to be sure that we debulk all the lipedema fat that we need to debulk to achieve maximum symptom reduction. So yeah, this is what we want to achieve with the liposuction. Now, a few words about the lipedema center here at the GMI. We are a relatively young lipedema center. We started back last year. We have already performed 34 liposuctions, the last of which were this Tuesday. I think they're actually watching from their bedroom upstairs, and they feel so nice, they said, in the hospital, that they don't want to go home. So I'm discharging them tomorrow.
Do you have any video of the hospital to show us?
Yeah, I'm sure I have some video when I finish with my presentation.
Yes. Okay.
I can share that. Yeah, because of the word center, and maybe in the UK, when we hear center, we don't really associate that with a hospital. It is a very big hospital. We have almost all different specializations here. We have 9 different surgical theaters, which are brand new. The first surgery was performed, I think, in February last year. And we're equipped with the state-of-the-art ICU, which does offer a substantial level of safety and security for lipedema patients, especially in later stages that you are removing upwards of maybe 10 liters. So you do need that safety. So yeah, I'm very happy that I managed to end up in a place that can offer such conditions for lipedema patients. We also have an in-house anesthesiology team. I always feel like the personal touch of you knowing your surgeon and you knowing your anesthesiologist and who is taking care of you. I think that's very important. And this is something that I'm trained very hard not to lose track of. Of course, when there is a lot of patients coming to you, you feel the need and the rush to do more surgery and do as much as possible. But always we're taking slow and safe steps to not lose this human touch and this personal touch, which I find is very important, especially in international patients. I think I've been blessed in my life and my career that I've had really many wonderful experiences with my past chiefs and the humanitarian work in Africa that was organized with Dr. Gods and everything. But the level of trust that is needed from a patient to travel without even meeting him from abroad, just through consultation of what they heard from other patients, to come to you for surgery, that's for me a huge responsibility. And that's why I find that I need to be there for the patient 24/7. I need to offer them the safety that is needed for such surgery. And that's why I don't really want to lose that human touch. That's why we're taking small steps and safe steps to still maintain that touch. Of course, if I was alone, I wouldn't be able to do anything. I have an amazing team around me. Dr. Yolanda Babamekru, even though she started 3-4 months ago, I think from week 1, she became like my right hand. She's always assisting me in surgery with lipedema patients. It's not just her surgical skills that I'm very impressed with, but even more so her human skills. She's a wonderful person, and she really brings a positive energy and really has been an amazing add-on to my team. Dr. Dimitra Onisiforu, even though she's a resident doctor, I would say maybe even wise beyond her years. She's the one taking care of the patients on the ward, letting me know when we have to check up on something. At the beginning, she was even helping all the patients with the compression garments, putting them on, putting them off, taking them off. Really, I'm extremely happy that she's with us, and she's great help on the ward. Christos Yabani is also probably the second person after Michelle that has made my life much easier. He is a physiotherapist with expertise in manual lymphatic drainage and lymphedema and lipedema. Not just Christos, but also his associate Marilena, both amazing. Christos also, we've managed such a good collaboration or working together. He even visits my patients in their hotel room or Airbnb to do MLD there, which is extremely convenient for the patient. And really, with him, I can sleep much more soundly. And last but not least, Marina, my secretary. Without her, the day just wouldn't work. Really amazing person as well. She also, something that I learned from Dr. Gotts, she also visits my patients on the ward, which I find really passionate, really human-like, which I also adds to this human touch that I was referring. So a couple of words in regards to how I do things. We set up a consultation. Usually patients contact me through my internet, my website, or my Instagram account. Then we set up a Zoom consultation or even over FaceTime or WhatsApp. I do request at least some photos and a questionnaire filled out. It helps me prepare a bit for the consultation. We go through the questionnaire then once together, and then we discuss a possible treatment plan. And at the end, I also send a list of measures and frequently asked question document, which, thank you, Michelle, was prepared with her help. So after the consultation, once we do decide to move forward with surgery, I do require that the patient gets proper compression garments, and not just for a couple of days, but at least for a few weeks, ideally for 6 weeks. Many thanks also to Lipoelastic, not just for today's event, but also for offering me as a physician the possibility to offer to my patients a 10% discount. I think Maria already mentioned. Not just for that, but also the amazing compression garments that they offer. I find it a great combination of very good quality and still not being overpricey. So yeah, that's one of the compression garments that I use. I do want the patient to have some MLD sessions before surgery. It also helps the physiotherapist back home to get a better understanding of the baseline, how the legs were or arms were before the surgery, so that they know what they're working towards after surgery. I always advise my patients on a healthy, balanced diet. It's one of the most commonly asked questions. What's the best diet in lipedema patients? Unfortunately, there's no recognized lipedema diet at the moment. Many patients swear by ketogenic diet or low carb diet or intermittent fasting. Unfortunately, we always want to work with evidence-based medicine. At the moment, there's not enough evidence to prove what's right and what's wrong. We definitely do not want you to starve yourself before surgery. It's surgery and it's a stress situation for your body, so we don't want you to starve. But for sure, we want you also to avoid junk food or unhealthy eating. So a healthy balanced diet is what we recommend. Some light physical activities depending on your capabilities, of course. I have stage 3 patients with already osteoarthritis, which is one common secondary comorbidity in stage 3. Unfortunately, they cannot, we cannot expect them to have a high degree of physical activity. I always advise on hydrotherapy because it sort of takes the weight off the joints, and it does help also with the, let's say, some light form of MLD. And I also require an anesthesiology document filled out, which I discuss with my anesthesiology team before you fly over. So we get all the preoperative exams before you come, because what I always want to avoid is you flying over, we do some exam, we find like your hemoglobin is low or whatever, and we cannot perform the surgery. So this is something that I find is a good idea, to have all the exams done before you arrive here, and me discussing with the anesthesiologist so that we know what we need before surgery. So I advise my patients to arrive in Cyprus 2 days before the surgery so that they're a bit more relaxed, not arriving the day before surgery. We have 2 international airports in Cyprus, in Larnaca and Paphos. We are located right in the middle of both, which is about 45-minute drive, so it's quite easy to reach. The day before surgery, we perform an in-person consultation. I will be examining you, and we will finalize the treatment plan. And then you will get to meet the anesthesiology team. So on the day of surgery, you should be fasting for at least 6 hours. We will meet on the ward. This is a video of one of my patients that took it from the surgical ward. It's on the 4th floor. It's the top floor. As you can see, it's quite a bit big building. It's many buildings actually connected with each other. And it's right on the top, let's say, of Limassol. So you have like a wonderful view of the coastline of Limassol, and it's quite, at least from the hospitals that I worked, I think it's the best view that I have ever seen. Once the markings are done, we go into theater, and then I'm just going to show you like some very basic stuff. I don't want to be too graphic. I just want to explain the whole setup. So what you are seeing now is the Vaser equipment. We are the only center in Cyprus that has the complete system. We have the infiltration pump, we have the Vaser, the PowerX, and the VentX, all from the same company. So we're also one of the few centers in Europe actually that has the whole setup like that. What you're seeing right now is me basically demonstrating the tumescent solution, the infiltration solution. This is another one of the, I'm not sure if you can see it, but this small cannula is sort of injecting some water, and I would be doing it afterwards under the skin of the patient. What's in this solution? I always have adrenaline in, but adrenaline is a vasoconstrictor. It basically sort of blocks the superficial skin vessels, and that helps us perform liposuction without having too bloody of a lipoaspirate. That's standard in every tumescent solution. What I've added since I've been back here in Cyprus, I've also added naropin, ropivacaine, which is a long-acting local anesthetic. Even though I do it in general anesthesia, I also add some local anesthetic. Since I've started using that, I've seen that the necessity of painkillers after surgery has dropped quite a lot. We don't really use opioids anymore. Of course, we offer them to the patients if they need it, but since we started with naropin, I've had a major decrease in the need for painkillers afterwards. So that's also one of the changes that I've had since I've been back here in Cyprus. So once the infiltration solution is in, then we wait for 20 minutes, and then we perform the Vaser. Sort of looks like a magic wand, let's say. Vaser, as I said, it's not liposuction as such. It sort of melts the fat. You have different modes and different percentages that you use. You always use a port to protect the skin. Right now, I'm not using Vaser. I'm just forming the channels that I will be going through afterwards, sort of just to avoid any resistance when I'm using the Vaser. And then when I do start the vaser, I always protect the skin because strictly speaking, it's a heat producing equipment and you always need to be aware of that and take care of the skin. So when you perform vaser and you've sort of melted the fat, then starts the actual liposuction. I was trained with PAL, power-assisted liposuction. I did, I don't know, hundreds of liposuctions with microair. Microair is wonderful. I loved it. Once I came home, though, we had an issue with getting microair here to the center because for about 6 months or so, it had lost its CE sign. We weren't able to buy it in Europe. Right now, it has its CE sign. It's gotten it back. But I already had bought PowerX, which is the same company of Ventex, of Vaser. So the difference is that you can sort of regulate how quickly the cannula turns and how many degrees it turns. So the disadvantage may be that compared to microair, it's a bit more slow. It takes a bit longer for to achieve the result that you want. The major advantage, though, that it can be much more soft to the tissue because you have the ability of choosing the speed that you're going, especially when you're going under the skin or you're doing a stage 1 lipedema. You don't want to remove too many liters, or maybe you're combining some other area. You want to do some formation of some lines. This really is a major difference to microair in that it gives you a much higher degree of sensitivity. So yeah, once we perform the liposuction, this is what we are basically aiming for. As you can see, the right side is infiltrated with an infiltration solution, and the left side has already been liposucted. And there we have achieved a good pinch test of, I used 2 centimeters. Again, it's a bit controversial how many centimeters you should achieve, but this is the result we are going for in surgery. So after surgery, I usually leave my patients for 3 nights in the hospital until we remove the drains. If patient wants to extend, of course, we can extend. That's not an issue. You need to wear your compression garments for 6 weeks at least. Many patients after the 6 weeks feel safer when they wear compression garments even a bit longer for at least a few hours a day. You do need MLD sessions, at least in hospital and at your hotel here in Cyprus. I prefer to do it daily. Back home, it depends on the swelling. Continuing with the nutrition that we already discussed. Traveling back home, ideal is 2 weeks or longer. 1 week, I would say, is minimal. I really do prefer to have my patients here so that if any issues arise, I'm here to take care of that. And I usually wait at least 3 months in between surgeries. So I don't want to sugarcoat things. I want to show like what to really expect. It's not a vacation when you come for liposuction, for lipedema liposuction. It's removing many liters. You will have bruising, as you can see. You will have leaking. It's uncomfortable. It's not painful, but it's uncomfortable for a few days. And often we have seromas, as you can see in the short video that is playing on a loop. Not always, but sometimes. And many cases, like the small one, you don't really need to treat, just with MLD and compression, but bigger ones might need to be drained. That's also another reason why I prefer to keep my patients for 1 to 2 weeks here in Cyprus, so that I can take care of these issues myself. And we will also have, especially in stage 3 cases, we will also have skin excess. This is also something that you need to expect. It's not every patient that has this degree of skin laxity after surgery, but when you're removing 15 or 20 liters from fronts and backs, then there will be skin laxity. And you need to be aware of that so you know what to expect afterwards. So I'm just going to show just a few cases. Prefer to leave some time also for Q&A. This is a patient that we already did 2 surgeries together. I'm going to show her last photos when we're doing the skin reduction part. We had removed 15 liters in total. These photos, unfortunately, are just post-op from the fronts. But as I said, I will show photos in a bit from the thigh lift as well. This is another stage 3 patient. In this patient, we had performed 2 liposuctions, removing 12.5 liters in total. She regained, I think she was about 65 years of age. She's from Cyprus. She regained her mobility, which was her main concern. Full disclosure, as we're a very young lipedema center, most of my post-op photos are after 6 weeks. Of course, we do need the 6 months follow-up, which is the final result. But of course, since we're a young lipedema center, I'm showing what I'm having. The important thing is for you to have an understanding that you do expect a significant reduction in the volume, the circumference. You do see some laxity, some skin excess, but it doesn't bother the patient. It doesn't impede her ability in mobilization, and that's why she's happy with the result. Again, the same patient from the side view to see the major difference in volume reduction. This was a stage 2 patient from the UK, 2 surgeries, 13.2 liters in total. Her main goal was she was training to become a police officer. She didn't want to have the difficulties with the training, and having had the surgery has helped her with the difficult training to be a police officer. This case was a revision case, one of the first ones I did. The major concern for the patient was to avoid at all possibilities the possibility of a thigh lift. We had discussed stage 2 patients. Stage 2 patients, sometimes we do need the thigh lift, sometimes we can avoid it. It depends really on the skin laxity and the skin quality. So here, maybe I was a bit more conservative in regards to the pinch test. I only removed 6 liters from the fronts and the backs, but I think we achieved a nice result. Yeah, I think to avoid the thigh lift, this was a good compromise. Another patient, 2 liposuctions in total. We removed a total of 24.7 liters. As you can see, in this case, a lot of skin laxity. Of course, here there's a need of a thigh lift that we will be performing later at a later stage. And again, from the side view, that you can see that there is a major volume decrease, circumference, especially in the thighs, but also on the lower legs. Not just the legs can be treated, of course, also the arms here, even with just a small amount of liters removed, we achieved a volume reduction. But this is a very interesting case. We'll get that to it in a bit, in a bit more depth, when we're dealing with lymphedema or lipolymphedema. I will explain the differences in a bit when I'm not showing the later photos. But one major thing that you need to be aware of when you're dealing with lymphedema or lipolymphedema, I will explain the differences later. You can treat it with liposuction. The major difference is, though, that you cannot expect to have the same decrease in the necessity of compression garments. So it's more often in lipolymphedema and lymphedema that you will need to keep wearing compression garments even after liposuction. This is something that you need to be aware of. Okay, I find that the patient has took better photos than we did pre-op. This is also something that we need to improve, our pre-op photos, but I think we achieved a nice result with this patient. This was another revision case. Just the fronts have been done to date. We are planning to do the backs in a couple of months. 7 liters removed. You can appreciate the result better from the side view that we have achieved a good volume reduction. And of course, we need another surgery to improve the backs as well. So let's go just a bit to the lymphedema and lipolymphedema that I shortly discussed. So on the one photo on the right-hand side, we have a lymphedema with the one-sided swelling. I will explain what's the difference between primary and secondary lymphedema in a bit. And we also have the lipolymphedema on the other side. So we have the combination of lipedema with lymphedema. Usually what I like to say is lipedema with lymphedema components. So there is some obstruction maybe to the lymphatic system, but the hope is that the lipedema is sort of compressing on the lymphatic tissue and debulking the lipedema sort of frees up the lymphatic tissue so that we decrease the lymphedema components down the line. So primary lymphedema means that the lymphatic system is primarily not there or not working. Secondary is because to some injury or some surgery. The major distinction, though, is fat or fluid dominant. What does that mean? So when you have lymphedema and it's fluid dominant, it basically means that the majority of the tissue in the lymphedema affected extremity is fluid. This is not a good time for you to have liposuction. So only in fat dominant lymphedema is liposuction indicated. If you have a fluid dominant lymphedema, you either need to improve your conservative therapy with MLD and compression class 3 compression to reach the fat dominant, to reduce the fluid dominant stage and then perform the liposuction, or to discuss the option of doing a microsurgical physiological therapy, an LVA or lymph node transfer. So I'm going to show this better with photos. This patient, I think we had been chatting for about 3 or 4 years. The first consultation, she was doing definitely fluid dominant. This is a pitting edema that you can see in the photo. This pitting edema was lasting for several minutes. So we discussed doing liposuction at this stage will not help you. So let's do really good compression therapy with class 3 and MLD. Let's see what we achieve and then we'll reevaluate. So really much respect to the patient. She did that perfectly, amazingly, with a conservative therapy, with a compression class 3 compression and the MLD, and she managed to get to a much lower degree of pitting edema, I think even under 30 seconds. And that's where we were able to perform liposuction. We have already performed this twice, and we have another liposuction coming up. So, of course, still we have not reached symmetry. Probably we will never reach 100% symmetry, but I think you can agree that we have definitely improved, especially on the lymphedema affected extremity. She also had lipedema on the other leg and the right thigh as well, which were also treated. And this is probably best seen from the side view. Now, just a few words on the skin excess management. This was one case of lipedema, which was treated from another colleague. Patient came to me with some remaining fat depots and skin laxity. So what we did here was basically a touch-up liposuction and a medial thigh lift. This is quite fresh. I think this is the 6-week photo, and the patient is quite happy with the result. Of course, we did also a tummy tuck at the same surgery, but this is the result of thigh lift. This is another thigh lift that we just did a couple of weeks ago. So after removing, I think, a total of 15 liters spread out over 2 surgeries from the front and the backs, then we performed the thigh lift. So all the skin excess from the medial thigh was resected. I always try to place the incision along the medial thigh so that it's not visible when you're standing up. Maybe you will also see the incision of the lower abdomen. She had a tummy tuck many years ago, and she had an excess skin Mons deflation, basically. So I also performed a Mons lift. And these are the on-table results. The photo is before any surgery, and the short video is right at the end of the thigh lift. This, of course, is not a lipedema patient. This is a massive weight loss patient. I'm just showing it to see that everyone is scared of the scars. Of course, as plastic surgeons, we don't want to have scars, but sometimes with the skin excess, we cannot avoid scars. So we always try to place them at a position that is less visible. And as you can see, in this case, we're able to place it right underneath. So when you're walking or having your arms up, it's barely visible. It's hidden in the lower part of the upper arm. At our center, we also have Morpheus 8. Morpheus 8 is brilliant. It started with facial aesthetics of offering rejuvenation of the skin. It's by InMode company. It's basically a combination of microneedling together with radio frequency. So it's like a sort of gun, let's say, that pierces the skin with many needles and releases radio frequency. And this does offer skin tightening. I know the company here states severe laxity in skin. Of course, you cannot expect a stage 3 lipedema after removing 25 liters that you will be able to treat the skin laxity there with just Morpheus 8. But for stage 1, stage 2, like specific parts, it does really help. And I can bring this into surgery with me. And the added benefit of that, when you're asleep, I can go the full 8 millimeters. I can go really deep because you're under general anesthesia, so it's not painful, and we can get the full effect. Now just some of my contact information, and I think that's it. Yeah, thank you very much. And yeah, I'm sorry that it took so long. I wasn't expecting it to go so long, actually. So there, thank you for the attention.
Thank you, Iakovos. That was a thorough and interesting, of course, presentation, and we are grateful for your time today. Now I would like to ask Margaret Skinner if she likes to say a few words. She's the second administrator of Dr. Iakovos Georgiou group, and she had her surgeries with him recently. Margaret, would you like to say 1 minute something?
I can just concur with what Michelle said. There's nobody like Dr. G, as we call him, because he is just amazing. He's literally, I mean, we use life-changing quite a lot, but he does change lives, and he literally changed my life. I thought at 66, I would never be able to go through surgery, and with my health conditions. But Dr. Georgiou worked through it, and I had my surgery on the 16th of April, and my next one is on the 19th of November, and I can't wait.
Rhonda, you are still in Cyprus. You are still in the hospital, or you are out? Can you say a couple of words?
Yes, I concur with what everyone has said. Dr. Georgiou is incredible. I feel safe with him. I'm actually at home with at a friend's. I was in the hospital for about 4 days, and I could have probably left on day 3, but because I had a thigh lift, I kind of wanted to stay an extra day, and he was very supportive of that. He explained everything quite clearly, although I'm finding I might not have been listening as closely as I should have, because I still keep going back with more and more questions. But anyway, I wouldn't trust anyone else but him to do my surgeries. So I'm very thankful and grateful.
Thank you. Ladies, please write your questions in the chat. Michelle and Margaret, you can get ready with the questions in a minute. Dr. Georgiou, I would like to ask you, what is the capacity in weight of the operating theaters there? Because we have doctors who operate 220, 125. And then I would like to know also BMIs. Do you take them into account? What is this area of demands, requests from your side?
So I do not have a BMI cutoff point. I do not have a weight cutoff point. Of course, each patient is a case-to-case decision. We need to have a consultation. We need to be sure that liposuction at that moment is the best treatment for you. But I do not have a limit that I say over this weight or over this BMI, I do not perform surgery.
Yeah, but the weight?
The waiting list, you mean? How?
No, the weight of the patient. What is the maximum weight do you operate?
I think our surgical table goes up to 230 kilos or something.
Oh, this is it's a very medical one. Yeah. Okay, Michelle, any questions?
We do. The chat is full of questions, and we've got some other questions from Instagram as well. But the first question on the list is, do you offer diagnosis online?
So it's always a good idea to have two consultants, like two surgeons or two doctors that are familiar with lipedema make the diagnosis. It does make things easier, but through my questionnaire that I've developed and through answering the questionnaire and me asking you specific questions, I can at least suggest a diagnosis. Sometimes it's not as easy. Sometimes you do need the in-person consultation. But many of the cases, we can be quite sure that it is lipedema just from a Zoom consultation, yes.
Brilliant. Margaret, do you want to ask the next one, or do you want me to do it?
Yeah, with high volume on legs, roughly how long are you in surgery?
So way back at the beginning, because I was all alone, it was taking quite long. So I think I even had the liposuction that took me almost 5 hours. Of course, that's not ideal, neither for me nor for the patient, of course. So that's why it was very important to find the right person to come and help me with the liposuction. That's why now having another consultant in my team, we have shortened the surgery time quite a lot. I think the last one we performed was about 2.5 hours or so. So yeah, I think that's about our average at the moment. That's about 2.5 hours, I would say.
So the next question is from a lady who has EDS and her joints are very damaged and she's requiring a knee replacement just now. So the question is, would it be better to have lipedema reduction surgery prior to orthopedic surgery or the other way around?
So unfortunately, it's not one decision for every patient. Definitely would need to have a bit more information to answer that concretely. But if the joint is still not completely destroyed, then I would suggest going through lipedema reduction surgery first, with the hypothesis that debulking the lipedema fat around the joint will change the posture and the way you walk, because when we have the fat depots around the knees, we kind of get this X-legs, it's called, that we're placing more strain on the outer part of the joint, which hastens up the destruction of the joint. So if it's still not to that degree, then probably lipedema reduction surgery first makes more sense. If the joint is already destroyed and you have insert a liposuction and not being able to move at all post-op, is also not ideal. So I would need to have a bit more information on a specific case to give her a specific question, concrete answer.
There's another lady asked, and this is a question I should have asked previous, so I apologize. Is the Vaser more effective on fibrotic tissue versus PAL or the other options?
So it's a very good question. And actually, so this is another thing that I didn't mention it, but Vaser is also ideal for revision cases, which basically means you have a lot of fibrotic tissue. So Vaser sort of goes through the fibrosis and sort of melts the fat and helps you avoid being over-aggressive with PAL. So PAL is the vibration assisted. You're basically doing the movement, but the cannula is also vibrating. With Vaser, you can go through the fibrotic tissue, melt the fat, and it makes life much more easier, not just for the surgeon, but for the patient as well. You have less bruising, you have less bleeding, and you have a nicer effect. So at least in my experience, I would definitely always use Vaser, especially in revision and fibrotic tissue.
This question asks, do you also treat the buttocks and hips when treating the backs of the legs?
It depends on the weight of the patient, the stage of the patient. So we're always bound by the 10% rule. We can't really go over the 10% limit. I mean, we can go just a bit, but not too much, because then it sort of gets a bit dangerous, let's say, for the circulatory system. So if a patient is weighing 100 kilos, I can remove up to 10 liters, let's say. So what I usually do in these cases, I start from the legs. If by the time I'm done, I haven't reached that 10%, that 10 liters, then I can continue with the lower back, the buttocks. But if I have reached it, then unfortunately, I would not be able to do the buttocks and the lower back at the same surgery.
Good answer. Some surgeons do not acknowledge that lipedema tissue forms on the back. Do you treat upper and lower back and flanks?
So also a very good question. So strictly speaking, lipedema by definition is on the extremities, but we need to listen to our patient. Many of my patients say, I know the definition is the extremities, but I also feel the same nodules on my lower back. I feel it on my upper back. I feel it under my many areas. I don't know if I would call it lipedema or not. I know that doing liposuction, though, does improve those symptoms. So regardless of what we call it, we know that doing liposuction there does help the patient. So I regularly perform lower back liposuction and upper back liposuction if the patient has symptoms there.
Great. This question's asking, what can patients do before surgery and after surgery to support healing? So looking for your thoughts on vitamins, amount of protein, prehab.
So usually I ask the patients to have like a blood examination, to have a look at the hemoglobin. Hemoglobin is a very important factor. We need to be sure that you are at a good level before we do large volume liposuction. If you have any issues, then we start taking iron, we start taking folic acid, we start taking vitamin B12. So this is what I usually recommend my patients before surgery. After surgery, arnica gel helps quite a lot with bruising. If we do have an issue with anemia, then folic acid again and iron. Collagen sometimes also helps. But these are the things that I usually recommend. I know many patients ask about diosmin or bromelain and many different supplements. Again, we always try to work with evidence-based medicine. Still, no evidence supports one way or another. We do know, though, that many of these supplements do increase the bleeding time just a bit. So that means bigger hematomas, bigger bruising after surgery. So it's a good idea to stop the supplements 2 weeks before and wait at least 2 weeks after surgery to begin them. And then maybe this is also a good time to chat just a bit about Ozempic and all other Wegovy and similar products. Many lipedema patients and many patients are taking Ozempic, and they're asking when should I stop taking Ozempic? Guidelines are still lacking a bit on that. Most patients are told 1 week before surgery. I always say at least 2 to 3 weeks to stop Ozempic, because it does delay gastric emptying a bit, and there's a slight increased risk of gastric aspiration during the general anesthesia. So Ozempic should be stopped 2 or 3 weeks before surgery.
Margaret, can I take a question? Dr. Georgiou, do you change your surgical plan for lipoedema patients? And I want to go further. Can you do full legs, full lower legs, for example, and full upper legs?
Yes,
or you do it only front and back?
So I do have my standard technique, which is usually fronts, one surgery, backs, other surgery, but no two patients are the same. It's like snowflakes. You have to take each patient as a case-to-case decision. So even though the majority are first fronts and then backs, I've had several patients that they didn't have any lipedema on the lower legs, and we were able to do the thighs, for example, 360 fronts and backs. I've had patients that were only needing liposuction on like a specific part. That's also an option. So even though I have a general treatment plan, it's quite flexible, it's dynamic, and we can make the choice, the decision, even at the last moment. So if you come here for the in-person consultation, once I examine you in person, we do see that maybe this would work better for you. We can even change it at that moment. We're not bound by the treatment plan that we had discussed before you flew to me.
So this answers the question of Farah Muji as well.
Yeah.
Ladies, continue.
It does. Is there a risk of fat accumulation in body parts that aren't suctioned?
A very good question. So let's take it one step further. We always talk about the stability of the results, the risk of recurrence of lipedema after liposuction. So we need to remember that fat is a dynamic tissue. All of us have stress situation in our lives. We stop our diet, we change our nutrition, we stop our physical activity. For whatever reason, we gain weight. What usually happens is, if you have had liposuction of the legs, fronts, and backs, how does a wound heal? It forms a scar tissue. It forms scar tissue that makes the fat accumulate more difficult. So what usually happens is, if you do gain weight after liposuction, for whatever reason, then it tends to not go to the areas that were treated. So it goes, for example, at the arms. It's not like lipedema is jumping from one area to the other. It's just because of doing liposuction sort of makes it more difficult for recurrence at the areas that were treated. So this is a sentence I actually stole from Dr. Gotz. He always said, lipedema is something in your genes. Lipedema is something that you have, and what we are doing with liposuction is symptomatic treatment. It's not curative. So you will always need to be mindful of your nutrition, of your physical activity levels. This is why me as a plastic surgeon, the physiotherapist, it's actually a very small role that we're playing in your treatment. The biggest role is played actually from the patient, and this needs to be explained to the patient quite clearly, that they always need to be mindful of nutrition and physical activity. They need to be mindful of their compression garments after surgery sometimes, or MLD. So yeah, I hope that answered the question.
Thank you.
This question asks, is insurance available for patients? Oh, it's just jumped. Hold on. Is insurance available for patients who want to buy it?
I'm sorry, I didn't quite catch that. Can you repeat that, Michelle?
Yeah, sure. Is insurance available for patients who want to buy it?
Insurance. Yeah, it's a good question. As of the moment, us personally as a GOC, we don't offer insurance as such. I know Maria has advised me in the past, and it's definitely something that we need to look into.
I think that you need to look into, because Dr. Siafliakis recently had reached an agreement with Lipoprotect, and they cover Greece as well, because on their website they say that they cover EU and the EFTA countries. So I think if you contact them, they may do it. It's €100 for a year.
Very good point. I will definitely do that. I think back when you had sent me the link, I tried to sign up somehow, but Cyprus wasn't in it. But maybe just contacting them directly, I think it's a good idea. What I can say though, the way that we work here at the GOC, we want our patients to feel safe. So we kind of work with lipedema packages, we have called them. So everything that has to do around surgery, at least for the time you're in Cyprus, if a seroma develops any infection or whatever, this is already covered in the cost that has already been paid before you fly over to us. But having extra protection for when you're back home is definitely a good idea. And thank you for bringing me into contact with Lipoprotect, Maria, and we'll definitely look into it.
Yes, bear in mind, Lipoprotect will not cover UK, America, and Australia. They cover only the EU countries, Switzerland, Norway, and Iceland. So this is a problem. UK ladies, they can do the travel shield insurance, which is for a few days, I think. But not UK, because they are not part of the EU.
Okay.
Ireland is in. It covers Ireland.
Just the UK that isn't covered.
Yeah.
Normal.
Yeah.
Dr. Georgiou, another question. Do you remove the fat pads on the outside of the ankles? Also, have you ever done removal of the top of the feet, lipedema tissue, and then the hyphenated typically doesn't grow there, but what, gosh, get my words tongue-tied here, but what if you see nodules or fibrosis tissue on the tops of the feet?
So the sides.
That's a few questions.
Okay, the sides of the ankles, like usually even just below the ankles, I do see that sometimes, especially with stage 3 patients, and I do address that. But I always say to the patient, it's the last place so that the swelling will go down. So the result there will be visible not at 6 weeks, maybe after 3 months it will be visible. So I do treat that. The feet, by again lipedema definition, the feet are usually spared in lipedema. If we have excess tissue on the feet, then I would definitely at least consider the possibility of having lymphedema. And then again, working my way through the improvement of the compression garments, making sure we don't have the pitting edema, hoping that the debulking of the thighs and the calves sort of frees up the lymphatic tissue and improves the feet in that way. But me personally, to do liposuction on the feet themselves, I don't really do that.
Thank you. And I can actually add, you did do my ankles for me, and they are going down finally, thankfully.
The next question is, what is your opinion regarding hyperbaric treatment?
Hyperbaric treatment. So I've read quite a bit on it. To be honest, I don't have personal experience with it. What I have read does sound that it could be something interesting. But unfortunately, since I don't have any experience with it, I can't really give my personal opinion on that.
Brilliant. So that's the questions that are in the chat for now. Just while we wait and see if anyone else has got some more questions, I've got some from Instagram. Some of them have already been asked, so I'll just read through them. This one here is saying, is the stomach a high-risk, difficult surgery to perform?
So it's not a difficult surgery to perform, but as all surgery, there are risks involved, and for sure you need to find someone that has experience with it. I do take some specific measures to lower the risk of any injuries. For example, the patient is usually, instead of being like in the prone or supine position, I kind of tilt the bed that way so that I'm always liposucting away from the rib cage. And you always need to be very mindful with every movement that you do. So it's not dangerous, but as any liposuction or any procedure, there are always risks involved. You need to be informed. You need to be sure about the qualifications of the surgeon doing the liposuction, and you need to be sure that it's done in a safe environment.
Brilliant.
I want to take Michelle to ask a question. Dr. Georgiou, you know that there, for the EU countries, there is a cross-border healthcare. Ireland, for example, I don't know if you are ready as a hospital, if you have done it, or you are ready to do it, to help patients whose health authorities can cover the cost of surgeries in Cyprus. And one of them is Ireland, of course. Have you come across any other countries? And what is the situation in Cyprus? Because we have Cypriots on the line as well with the healthcare authorities in Cyprus. Have you been in contact? What is their view about the lipoedema?
So let's start with Ireland and the treatment abroad scheme, I think it's called. So we are a hospital treating state patients, so we are able to sign and fill out the forms for you. I think there's two ways of going about it. You either pay for it yourself and then you fill out the documents and then you get the money back, or there are other documents that you fill out and the government then basically directly pays the hospital. So we've already done it the first way. The second way, I have patients that are coming that we need to do it that way. And we're a full hospital, so I don't expect to have any issues with that. In regards to the Cypriot healthcare system, YESI, unfortunately, it's lagging really behind. To be honest, I don't really see it being inducted in YESI anytime soon. The most important thing, we would need a sort of board that would be able to decide on a case-to-case decision of what is lipedema and is this lipedema and should be treated as a lipedema, because otherwise it would become absolutely dangerous for anyone to perform the surgery without any proper qualifications and with wrong patient selection. This is definitely something that I want to work on. But as of now, I don't see it happening, at least this year.
Okay, ladies, you can continue.
Thank you. There's some more questions coming on the chat. So let me just move my mouse. Are there any long-term complications from surgery?
Long-term complications from surgery. So possibilities for long-term complications would be, for example, lymphedema. So if you're not careful the way that you do your liposuction, going crisscross, damaging lymphatic tissue, there is a risk for lymphedema. At least in the cases that I did, to my knowledge, at least, I haven't had that issue. But it's something that if you do not find a qualified lipedema surgeon, that it's a possible complication. There is always the risk of not having a result as you expected. You do not have sufficient symptom reduction, which is also a long-term possibility. I think those are the major ones that the question is referring to.
Thank you.
How long did you train under Dr. Gotts?
So I was with Dr. Gotts from 2017, so I think 5 years in total. I started my plastic surgery residency a year before that with Professor Sinnes. Actually, my first contact with lipedema patient was at the clinic of Professor Sinnes in Berlin. And I remember the first lipedema patient that I saw made such a huge impression on me. Like she felt so vindicated that someone knew what lipedema was. And it was actually because of that case that Professor Sinnes sort of brought me into contact with Professor Gotts. And it's actually a funny story because I went to visit Dr. Gotts to have like an interview, and well, everything went very nicely. And he said, look, I have to be honest, right now I don't really have a position. So keep looking for something. If anything comes up, if a position opens up, I will let you know. So of course I was a bit disappointed. I wanted to join his team. So I found another brilliant, it was a burn center near Berlin. So I got the position there, and I was on my way with my car to actually sign the contract. And my car broke down in the highway, right in the middle of the street. And I was waiting for the tow truck to come and pick me up, basically. And as I was waiting, Dr. Gotts called me and he said, "You want the job?" So yeah,
that is very good.
Yeah. So if it wasn't for my broken car, then I wouldn't be here. So yeah, that's a kind of funny story. Yeah, like small stuff in life bring huge differences.
We have said that quite a bit, actually. The universe tells us when to do it and how to find you. So
yeah.
This next question is saying, I know that you're advising to stay at least 1 week after surgery, but if all is going well, is there any possibility to fly home once discharged from hospital?
So as always, it's a case-to-case decision. If everything is going well and you are, of course, open to the idea of me at least recommending that you stay longer and you book a flexible ticket, and it is something that we can discuss. I mean, I even had a patient that flew to back home even 2 days after surgery, and it was a very long flight just because of a family emergency. So it is possible. It's not ideal, but it is possible. But again, it's not something that I can really generalize on. It's something that we need to discuss during the consultation.
if 10% hasn't been taken from the fronts, can MONS be done whilst under anaesthetic at the same time?
So if we don't reach the 10%, we can do some other body part. We need to remember, though, that when we're doing a body part, it's ideal that we finish with that body part. If I start doing the front of the legs and we see we have another 2-3 liters left, and then I need to turn you around and I start doing the thighs and the backs of the thighs, and I reached the 10%, so I can't continue, and I haven't reached the 2 centimeter pinch test that I need to do. And next surgery, we need to basically go through the same area. We already created fibrotic tissue. Definitely not ideal. So if it's possible to start another area and finish it, then it's something that we can discuss. But if it's doing half there, then it's not a good idea.
Thank you. Michelle?
Yeah, just looking for the next one. How long is your waiting list for surgery just now?
So since we're young, relatively new lipedema center and a relatively new surgical center, we're quite flexible with our surgical times. I'm trying to keep a few slots open each month for international patients because I know how difficult it is for you to organize everything. I cannot guarantee that I will have something for you by next month or the next 2 months, but I will try my best within the next 3 to 6 months to find an appointment for you.
I would like to ask Dr. Georgiou about the cost of surgeries. You know, I am very mindful about the cost, as my group's objective and mission is great surgeons at reasonable prices. So ideally, what is the cost of a surgery?
So, as I said, we work with lipedema packages. We try to include everything in the price that you pay before you fly to us. At the moment, we're offering the package of €6,500, €6,500 per surgery. And that includes the general anesthesia, the surgery itself, the hospital stay, even if we need to extend the medication and the MLD in the hospital. It does not include the MLD after surgery when you're at the hotel, but all else is basically included.
And what about the thigh lift? What is the cost of a thigh lift? Or what do you call the one around the waist?
So it's similar price. So the only thing that costs more is if I need to turn the patient. If I need to turn the patient, I'm almost doubling the surgical time. And as you know, surgical time is the most expensive thing in the hospital. So as long as I don't need to turn the patient around, it's along those lines. If a patient wants to add something, if we're doing, for example, liposuction of the legs, and the patient wants to add the abdomen or under the chin, or more fails, for example, there will be an add-on price, a small add-on price to account for the added surgical time. But we're working with this €6,500 basis.
Thank you very much. Thank you.
Regarding skin tightening, is there a particular reason you're not using argon or RG plasma?
So I think at the moment the most in vogue machine for skin tightening is probably J plasma, Renuvion. It's something definitely that is very interesting. Many surgeons that I very much respect, especially Dr. Bruno, is using it, and I have seen some good results. It's definitely something that I want to look into the future, not the far future, the near future. But at the moment, currently, I'm not offering.
They say that Renuvion is the king of the skin tightening.
Yeah.
That's what they say.
Yeah. So I do agree that it's something very interesting. And I think we will be able to offer it soon. I'm a bit skeptical that in stage 3 patients, you can get away with skin tightening just with Renuvion. Yes. I think stage 3 will need a thigh lift. But it will improve the situation with stage 2 patients.
Michelle.
Okay, this next question is asking, would skin removal be covered under the cross-border directive?
As I understand the stipulations that are in it, just the skin excess removal wouldn't be included in the...
No, it's not.
Yeah.
It's not, yeah.
Are you there, Margaret?
Yep, I am. Can you explain what pain relief options you use? For example, being EDS positive, I'm very resistant to local anesthetic, as well as morphine-derived meds, but tolerant to phenytoin.
So I recently had a patient, a chronic pain syndrome patient that was already on regular tramadol and paracetamol before surgery. So of course you cannot expect right after surgery you will stop taking your pain medication. You will definitely need to continue for at least the immediate postoperative period your pain medication as you were taking it before. At least with this patient and other chronic pain syndrome patients with the long-acting Roacaine, I was able to make the pain for the first 24 hours much more subtle and tolerable. Post-op, we do need to discuss with the anesthesiologist that is taking care of you and visiting you daily on the ward if we need to adjust the medication. So yeah, it's everything in communication with the anesthesiologist, which is specially trained on pain management, basically, that we make the decisions.
Okay, I've got a few more questions here. Is there anything in the chat actually, or will I just finish the ones? Oh yeah, a couple more. So the lady's saying, sorry, not taking anything before. Do you use morphine-derived products for post-op?
Not as a standard. We do have them, of course, at the hospital. So if a patient is not coping with the pain just with the normal analgesics such as paracetamol and ibuprofen, then we may consider some opioids. But in the vast majority of the patients here, we don't really need them.
And another question. Treatment abroad scheme, is different from the cross-border scheme. Do you offer both? And has anyone been successful with treatment abroad scheme?
So as I said, we're quite new here with the documents. I have already filled them out. I haven't had a response as of yet, but we are a hospital and we are able to fill out the documents. As soon as I have a response one way or another, I can let you know so that everyone in the groups know what we're dealing with here.
Dr. Georgiou, we will have 10 minutes more. Michelle has some questions. And then we will let you go because we know you had a long day today.
Okay, let's see if we can go through these ones quickly. So this question's asking, ideally, it's better to do lipo first and do a skin lift later. But are there times where you would do both at once?
So if a patient has had liposuction in the past and she only has skin excess, of course you can go straight forward with the thigh lift. If the patient has a lot of lipedema fat still untreated and not enough skin laxity, then I will always recommend doing first the liposuction to achieve skin laxity and then thigh lift second. If a patient that is like a stage one wouldn't need a thigh lift. A stage 2 patient that we could possibly perform liposuction and simultaneously a thigh lift, very rare cases, it's something that I would be open to, but the majority, they first need a good liposuction to achieve a 2 centimeter pinch test and then allow enough time to see how the skin retracts by itself. It's not every patient that needs a thigh lift. Many of the patients, some of the patients, they have skin that will retract by itself. So we can avoid the thigh lift. But if there are patients that would need this combination, of course, I would be able to discuss it at least with them.
Okay, brilliant. Why is it preferred to treat the front before the back?
Couple of reasons. So backs tend to be a bit more difficult because you're lying on them all day. It's more uncomfortable for you. So doing the fronts first and sort of knowing what to expect makes it a bit more easier for the backs. That's the first thing. Second, we usually can achieve bigger lipoaspirate amounts, volume from the fronts than the backs. So that kind of offers you better mobility post-op than the backs. But of course, it's again case-to-case decision. I had patients that we did the backs first because they were more symptomatic in their case than the fronts. So again, it's a case-to-case decision.
Okay, thank you. This question is asking, how can the loose skin be treated if it's in the buttocks as well as the legs?
So if it's in the buttocks, you usually need a buttock lift. I do sort of auto-augmentation, it's called, depending on the patient, of course. So if, for example, the patient has also excess skin in the belly area, you can combine it with a total body lift. You can go all the way around. The excess skin on the top of the buttocks, instead of throwing it away, you sort of use it to place it over the buttocks, under the skin, to offer more projection, to offer like a butt lift. So that's a brilliant thing about plastic surgery. There are so many options. It's such a wide spectrum, so many techniques, specialization, that each patient needs to be discussed like case-to-case decision to offer them their best technique for them.
This question asks, what's the process for a thigh lift?
So the thigh lift, I always do it strictly vertical. The reason for that is A, you avoid injuring the lymphatic tissue, and B, you avoid placing the scar along the groin, which over time sort of drops a bit lower, like a few centimeters. So when you're wearing your bikini, it becomes much more, bikini or underwear, it becomes much more visible. So that's one major characteristic of the way I do the thigh lift. I always do it liposuction assisted. So the first stage is you basically do a very aggressive liposuction of the skin that is to be resected. And then you sort of peel away the skin. It does sound quite graphic, and it quite is. But the benefit of doing it that way is it's much more lymphatic, protecting the lymphatic tissue. So you avoid removing lymphatic tissue. So that's, I think, especially in lipedema patients, the best technique.
Okay, I think there's some more back in the chat.
There are, yes. This is a good question. Do you perform surgery on women over 60? Any special considerations? And is loose skin much more of a problem for people of this age? And she's not sure if it's covered in this topic already. She's just joined the call late, and thank you very much for your time.
So I love my patients all the same. And I really have had some wonderful patients over 60, present company included. What I do find is that patients over 60, they're very appreciative. Not that the younger ladies are not appreciative, but usually patients over 60, they have gone even decades without proper treatment, without proper diagnosis. Maybe they have even visited a few plastic surgeons that were not willing or able to have them as patients. And so you do get the sense of having an extra appreciation. That's the first part of the question. The second was in regards, I think, to the skin excess. What I do find is usually it's the younger patients that are a bit more demanding, let's say, on the thigh lift. I find that patients over 60 usually accept some light or moderate degree of skin laxity more than younger patients. But of course, I have performed surgery also on over 60 patients, and that's absolutely fine. The last part of the question was what specifics do we need to be mindful of with over 60 patients? I would prefer the patient to stay a bit longer in Cyprus, just to be extra cautious with everything that I myself can take care of if anything arises. Maybe the mobility is not ideal. Maybe we do have some issues with blood pressure or whatever. And for sure, we do need to discuss the case even more thoroughly with the anesthesiology team to see if there's any extra examinations that we need beforehand.
Can I just add before we go on to the next one, that as most people know, I'm 66 and I just had my first surgery, and it was just the most amazing experience of my entire life and the best thing I've ever done in my life. So never be frightened, because you're well looked after, and I can't believe I've got knees again and I look better. My son actually said today, "Mum, you look better than I can ever remember seeing you." So there you go. I'll let you go on with the question. Sorry.
Oh. Can you do an outer and an inner thigh lift?
Can I do an inner thigh lift? Outer
and inner.
So outer thigh lift, going from the outer, just from the outer, I haven't really done that. What I have done is like 360 thigh lift, like going all the way around the thigh, that I have done. But I didn't, like in the beginning. I'm a bit concerned about the lymphatics with that technique. And I'm also a bit concerned about the long-term result with the scar, because we cannot stop gravity, unfortunately. So gravity always pulls everything down. So placing the scar circularly, basically you place it high up at the beginning so that when you're wearing your underwear, it's kind of hidden, but over the next few years, it's going to be lower and lower, and basically it's going to end up on your thigh. So in lipedema, I'm happy with the inner thigh technique, and like I don't see a reason why I would need to change that. But as always, it's a case-to-case decision, and I'm sure there are patients that at least the option should be discussed.
The reason she's asking about outer and inner is about saddlebags.
So saddlebags, I would prefer to, if we cannot repair them, because what the good thing about doing the fronts and the backs in two separate surgeries, being very aggressive. So basically, with each surgery, you're sort of detaching. I don't want to be too graphic, but you're sort of detaching the skin from the connective tissue. So what is happening is a sort of redraping of the skin. It kind of makes new folds and sort of readjusts itself more symmetrically around the thigh, the front first, and the back second. So when we do that in 2 stages, and then we come into the thigh lift, many cases we can improve the saddlebags just with an inner thigh lift if there has been sufficient good redraping of the skin. If that hasn't been achieved, the next idea I would have is maybe doing the butt lift that we discussed, placing the incision on the lower back so that you can lift the skin from the saddlebags without placing the incision along the groin and turning the lymphatic. So that would be another idea that I would be looking into for the saddlebags.
Michelle, can you do the next ones? There are 2 more to finish here.
Yes, of course, no problem. I'm just finding it. It keeps moving up my screen. Okay, would you do lipedema surgery on someone that's already had lipedema surgery with another surgeon but isn't happy with the results?
Many of my cases are revision cases, and yes, I would.
Okay, that's great. Is fat transfer possible? Or does it carry a risk of spreading the lipedema fat to other parts of the body?
Very, very good question. So again, we like to work with evidence-based medicine. According to my knowledge at the moment, there are no publications proving that if you take lipedema fat and transfer it somewhere else, it will form lipedema there. From my point of view, it does sound logic. I mean, if I take pathological fat cells from one area and put them in another, then they would still be pathological fat cells. So I don't really do that. If I need to perform some fat grafting in lipedema patients, then I avoid using the lipedema fat that I extracted from the extremities. I would prefer to take some from the abdomen, for example, if the patient, of course, doesn't have any symptoms there. So yeah, fat grafting I wouldn't really do with lipedema fat.
Can you give us another 7 minutes?
Sure.
Okay. Michelle, your questions from the Instagram.
Okay, brilliant. A few of them you've already answered, to be fair. Here's one here. Would you advise going on HRT if you had lipedema?
Ah, lovely question. So yeah, HRT, very important question, something that is asked very often. And yeah, to be honest, at the moment, there's not enough evidence to show one way or another. I do know that I have had patients that have said that going on HRT has made the lipedema symptoms worse. And I've had patients that said that the hot flashes and the perimenopausal symptoms were so horrible that made the lipedema that they already had even worse. So I cannot give you a general answer, I'm afraid. I wish I could. I would definitely, what I usually recommend is discussing with your gynecologist. If your gynecologist doesn't have any clue about lipedema, I would recommend you bringing them into contact with a lipedema surgeon to discuss all options. If you're considering liposuction lipedema reduction surgery, then it might be a good idea to do the surgery before you go on the HRT, because HRT does slightly increase the risk of a thrombosis. And there's also the good possibility that reducing the lipedema symptoms maybe even improves some of the perimenopausal symptoms. So again, you need to discuss it with the patient and hopefully in an interdisciplinary manner also with the gynecologist. But I cannot say don't go on HRT if you're having symptoms, because I know they can be quite horrible.
Brilliant. I've looked through all the questions and you've answered the other ones already through either other questions or in your brilliant presentation. So thank you very much.
Thank you.
Ladies, can you please unmute your microphones? Can you unmute, all of you? Unmute all of us if we can. So we can just say thank you to Dr. Georgiou for his generous time and his thorough presentation. Of course, as we said, we do it as part of our educational sessions with various surgeons, and today it was a turn of Cyprus. Any one of you who would like to contact him, he gave the contacts. He does the consultations online. And we look forward to have a future session with him again end of the year or next spring. We can also give a rise of applause. And usually we ladies, those who wish, we can stay on to chat. This is what we do after each Zoom presentation. Dr. Georgiou, thank you very much. Dr. Manavella just sent me a message from Argentina for the excellent presentation. Congratulations. And next week I am having with him, sadly it's 12 midnight for me because of the time difference, but he has a big, I manage the Argentinian group also, and he will have a lot of audience because there are only 2 surgeons in Argentina. So we are doing a Spanish speaking session next week.
Nice.
Thank you very much. Good night.
Thank
and
you.
see you in Cyprus.
Thank you.
Ladies, those who